Speakers, can I invite Paul Worley to the stage to commence proceedings by setting the scene? Thank you.
Thank you, Jenny. It is wonderful to see such a crowd here. I too want to acknowledge the Ngunnawal people, custodians of this land, not just for being that, but also for being an inspiration to me, along with Aboriginal peoples across the land, of the principles that that we can learn from today in implementing the task that I've been given to implement a national rural health workforce strategy around rural generalism. Those particular principles that many of you may have heard me talk about, the importance of place, the importance of country. Our pathway has to be based in our country, it has to be based rurally. The importance of a holistic understanding of health, of a bio-psycho-socio-spiritual understanding of health. Rural generalism has to have that broad understanding of what it means to be healthy. The importance of cultural safety and the intolerance of systems that have been set up across rural Australia where we have culturally unsafe practice. And I'm not talking there about overseas trained doctors, I'm talking about city trained doctors not understanding the country and country people having to receive their care from people whose culture is a city culture or a culture foreign to them. And the principle of all Aboriginal medical services that we can learn so much from when we're designing this pathway, which before the Aboriginal medical service are two specific words. Those words are community controlled. Our National Rural Generalist Pathway has to also be community controlled, rural community controlled. No longer can we be the poor beggars looking for the scraps that come out of the cities, but we actually now have the opportunity to have that sense of place, that sense of holistic understanding of health, that sense of safety that we can create, and the control in rural communities. But I wasn't asked to speak about that. I just saw Dennis on the way in, and it just reminded me that I have to acknowledge how much of my thinking has been influenced by Aboriginal and Torres Strait Islander people, and thank them for that. I want to ask, what has the recent listeria outbreak in Griffith, and I recently went to Griffith and ate there, and my family thought I was very courageous for doing that. What is that listeria outbreak in Griffith? A small farmhouse in Adelaide and a country boy in Scotland who, by the age of 59 or 60, had given up on his research ever having any impact on the world. What have they got to do with rural health research and some of the things that have changed the outlook for people around the world? Well, the small country kid who gave up on his research, which, by the way, happened because of a mistake in his lab, gave up on his research ever making any difference to the world, was Alexander Fleming. You probably know that he was the person who discovered penicillin from the penicillium fungus that infiltrated his beautiful experiment and created chaos. And thankfully, as a researcher, he was able to, instead of see this as an error, be curious about what was going on. Strange that the people who invented or actually discovered DNA likewise discovered that from perceiving what had previously been seen as an error in X-ray refraction as actually showing something very substantial about the structure of matter. The presence of protons. But by the time he got to 60, Fleming had given up on ever being able to translate his discovery into anything meaningful for humanity. One of the struggles we face in rural health is how can we translate our research into policy? What happened was a young kid from Adelaide who grew up in a ranch-style house on the outskirts of Adelaide as it was then, and one who was very well known to Canberra, Florey, came along. He at that stage was in his 40s and had received his PhD and had made a few impacts in terms of his work. He'd become a professor. That was, impact enough, isn't it? You've done what you need to do. But he became curious about this strange drug that had been developed but didn't seem to go anywhere. Timing was very important. At the same time as Fleming gave up and Florey and his colleagues started looking, the world was at war. Suddenly there was money available for something that might help soldiers. What was the thing that was killing more soldiers than bullets? It was infection that was killing more soldiers than bullets. But Florey his task was to discover how can you produce more penicillin. So the drug had been discovered, but you couldn't produce it in sufficient quantities. You couldn't scale it up enough to have an impact. So where did the key understanding for that come? They looked across the world for soil organisms that could produce this fungus and produce this penicillin. Where did they find it? They found it in rockmelon. They found it in rockmelon in the US, in Illinois. They found a species of penicillium that when it was treated with some x-rays, again there was some technology involved, was able to produce 1,000 times more penicillin than the strain that had flown through the window in St Mary's in what is now Imperial College London. So the farmers in Illinois, they never got the Nobel Prize, but it was their rockmelon, like the rockmelon in Griffith that we've all been complaining about, the listeria. Instead of complaining, they were curious. Instead of complaining, they were curious. Why did Florey get the Nobel Prize? Was he interested in its impact on humanity? He actually said no. He wasn't doing his research because he could see a great impact on humanity. He was doing his research because he was curious. And this was a problem that needed to be solved. An interesting similar response when I asked Michael Marmot, now Sir Michael Marmot, why he got involved in the social determinants of health research when he was at the University of California, Berkeley. And he said, because I was curious. And what's more, I was around people who were curious. I was part of a research team that kept asking questions, that didn't take no for an answer until they had found a way to come to a yes. Michael Marmot is another example of a person who has taken a research idea and taken it to scale. The social determinants, in many ways, can be looked at a very micro level. Through your qualitative research, you can see the differences in the social environment of particular individuals, small communities, and you can make assertions about the impact that that environment has on their health. But in order for that to translate to policy, that needed to move from small studies about individual locations and towns to something that could influence the WHO. Read what Sir Michael Marmot did in the Commission on Social Determinants for Health. And who did he involve in that scientific work of implementation? He involved health ministers from around the world in that work. I am so fortunate to have in this position the support of health ministers, not only federally, but also in each of the jurisdictions, who are committed to working with us to improve the health of rural and remote Australians. But what they need in order to do that is research that is not just applicable to one town. Many of you will have heard, and I'm sure you've often used the phrase, if you've seen one rural town, you've seen one rural town. Now there's a truth in that, and there's a hazard. The truth is that yes, we are all individuals. And each of us in this room are individuals, as is each rural town has its own characteristics. The hazard is that if our research continues to focus on the ethos of you've seen one rural town, you've seen one rural town, it will never translate into policy. Because for policy you need to see what is common across the differences. You need to develop scale. You could equally say, you've seen one GP college, you've seen one GP college. If our two colleges had said that their importance is actually in our differences, rather than in coming together in the Colin Grove Agreement and saying, actually, what do we have in common when we're looking to influence the health of rural communities, we would still be in a situation where we actually couldn't define what a rural generalist is. The two colleges needed to separate being distinctive from, for policy reasons, what do we have in common? How can we scale up our efforts in order to have an impact on the whole of Australia, rather than retaining our individual identity at risk of the influence of the country? If I reflect on my career, and I've been fortunate to have a wonderful career and to now have the opportunity to work with you in what I see as a research translation position, called a commissioner, but in many ways here to translate the research that many of you in this room have done. If I reflect on that, my career started by being prompted to be curious. And that was a prompting by the team that I was around. Firstly, I was prompted to be curious by the rural doctors that I was surrounded by in rural practice. We were angry. We were angry that the universities, the colleges, no one was actually looking after the bush. They were looking after the city really well, but they were not looking after the bush. If we had stayed angry, we would still be angry and nothing would have happened. But instead we became curious about, well, what is it about the system that is making it this way? And what can we learn from the system that can actually transform it to be another way? I joined the university to extend my opportunity to be curious, to be part of the solution rather than part of the angry crowd complaining about the problem. Although I maintained my anger for a good while, for those of you who know me in the university. Was given the opportunity to work with a man called Chris Szilagyi. Very sadly passed away from lymphoma during my PhD. But he said, Paul, you've got to get more curious about this. You've got to get more thinking about why this is happening. So while we were instituting what became known as the PRCC, the longitudinal approach to actually teaching students in a rural community rather than a tertiary hospital, he said, why don't you study this? Why don't you study this and become curious about why it's happening? Not just what's happening, but why it's happening. So I did. But if that study had just stayed the study of a small group of 8 students in the Riverland, one rural community, you've seen one rural community, one rural education program, you've seen one rural education program, that would have had no impact. So it took a person like Lucy Walters in Mount Gambier to say, I want to replicate that. I want to do that again. I want to see if we can do that in Mount Gambier. And then it took a person like Roger Strasser to say, I actually want to do that for my whole school. And I want to do that not just in the undergraduate area, but I want to do that for postgraduate education as well. I want to line up from high school through to fellowship. Well, they actually call it board certification in Canada, in Northern Ontario. But I want to line up that principle and say, we can do that for our whole school. By the time, that was 10 years after we'd started our work in the Riverland. 3 years after Roger does that, a group of medical schools around the world say, we actually need to form a network called the Training for Health Equity Network, to join our forces and say, instead of what are the differences in our schools, Cuba, a school of 10,000 students, Riverland doing 8 and Mount Gambier doing 8, slight difference there. Instead of the differences, what are the commonalities? What can we identify that could be replicable across all medical schools in the world? So the Training for Health Equity Network, founded in 2008, that then enabled an organisation, coming back to Michael Marmot, the WHO, to say, actually we have a worldwide problem. We are short of millions of health workers in rural and remote communities. How can we scale up our education processes to actually meet this need? And through the research that had been done through organisations like VNet across the world and people here in this room, they were able to come up with evidence-based recommendations on how you could scale up and transform the health workforce. That was 2014. So when I'm given the opportunity now to form a national rural generalist pathway, and I promote the idea that needs to start at high school, needs to be based in place, as our Aboriginal people will say, needs to be continuous through medical school in rural areas, through junior doctor training, through fellowship programs, all based in the rural areas, migrating to the city for rotations where necessary, and you need to see what's happening in cities, but where the student calls home in a rural postcode and a rural electorate, I can know that that policy recommendation is based on solid evidence. That policy recommendation is not based on the evidence of one town or one region or one country, but it has actually been scaled up to look at evidence that we can bring here to Australia that has worldwide support. So can I encourage you as rural and remote researchers to find teams that encourage you to maintain your curiosity in the face of what can sometimes be a sort of monoculture within a small region? Can I encourage you, no matter what your research method is, to think about not just the curiosity about differences, but be curious about what is in common. And that is not just in numbers. It's not just the Fiona Stanleys of the world who are able to create, 7 years after they graduate from medical school, a database that enables us to change the world in terms of spina bifida prevention and folate deficiency. But her curiosity came from visiting multiple rural communities and saying, what is in common here rather than what is different about each of those things? So be curious, look for what is common, and then have the courage to stand up and say, it doesn't have to be like it's been. We have the evidence, we can show, and we can move ahead. Thank you.